University appointed governor. Welcome, Richard. Look forward to you participating, being part of the governing group with us. Julie, do we have any apologies for absence?
Yes, I've got apologies from Marcella, Pooja and Sophia.
Okay, thank you. And declarations of interest. Do we have any declarations from anyone attending the meeting? No? In which case, let's go on to the minutes of both the last formal meeting held on the 11th of June, but also the extraordinary meeting that was held on the 16th of July. Are there any corrections or amendments people feel necessary to those minutes? Okay, that is a no. And as far as I could see, there were no outstanding actions from those. Which brings us on to the Slough Public Governor election results. Julie, do you want to take us through this?
Yeah, this is just to formally note that Sharon O'Reilly was elected as a governor for Slough.
That's good. Welcome, Sharon. That brings us on then to the first substantive matter of the morning, which is a presentation by our external auditors to you. Ernst & Young are fielding Alison Kennett. I can't see on my screen if Alison's with us. I'm sure that she is. So
yes,
Alison,
I'm with you.
super. I'll hand over to you.
Okay, thank you, Chair. So you'll see on page 13 of your papers, there's our independent auditors report for the year ended 31st of March 2025. And I'm pleased to say we gave an unqualified opinion, which is the opinion that you actually want. The audit went very well. It went very smoothly. The officers gave us the information we wanted very promptly. And so we was able to report to the audit committee back in June. We had an audit results report, which showed minimal findings, and we also had an auditor's annual report, and in there that shows the arrangements. We comment on the arrangements for securing your value for money for the trust, and the criteria for that is items such as financial sustainability, governance, improving economy, efficiency and effectiveness. And within there, we were happy to report that there were no significant risks identified. So all in all, the audit went very smoothly, and there was no major issues to report. So happy really to take any questions that you have.
Alison, thank you for that report, and it's a very positive one from our perspective, so thank you for that. Any questions from the governors in terms of Alison's report? As if you're getting off very lightly there, Alison.
Thank you.
Alison, can I just say a big thank you both to you and also to Paul Gray and his team in terms of the work that both of your teams undertook in terms of bringing all of that to a conclusion. It does look a very positive report, as I say, and thank you to both of your teams. If you could take that back from us, it is greatly appreciated in terms of the work that you've undertaken for us. Which brings me neatly on to the annual report and accounts presentation. Julian, Chief Executive, is going to take us through, supported by Paul, in terms of the finance aspect. So over to you, Julian.
Sorry, Chair, I had a problem getting on camera and off mute. Can you hear me okay, Mark?
Yes, can now. Thanks, Julian.
Thank you. I panicked then. It doesn't happen for the AGM. Good morning, everybody. I know most governors, but for the new governors, I'm Julian Ems. I'm Chief Executive, and I get two attempts at this presentation because I'm obviously doing it for the AGM a little later. It's a statutory requirement that we kind of do a review of the year from the annual report. So the annual report gets laid before Parliament. It is set out the kind of content of what's in there, and I don't try and cover all bases, but just give a flavour of what's happened between, in this case, April 2024 and March 2025. So if we just go to the first slide, please, and we can pass over this fairly quickly, because it's really for those people attending the AGM who get confused about our organisation. So just there we go. So it's just an introduction to Berkshire Healthcare, because experience tells me sometimes we get questions about the Royal Berkshire or Frimley. So it's just an introduction to us and the fact that we're the provider of the community and mental health services across Berkshire. And if we could just click on to the next slide, please. Yeah, although the 10-year plan, long-term plan for the NHS was published after the period under review, prior to that, the government had clearly set out its priorities for the NHS, which I think for an organisation like ours was particularly encouraging. So the shift to prevention, a recognition that we needed to particularly look at improving long-term health outcomes, a strong emphasis on community-based care, and particularly saying, you know, acute hospitals should just be for acute care and nothing else, and we need to do community-based services, home-based services that are more patient-centred, and a move from analogue to digital systems. And that was, again, particularly welcoming for us. So in the NHS, there's a digital maturity matrix of all 200 organisations in the NHS, and Berkshire Healthcare currently is rated #1 in the country for digital maturity. So we're well placed to help support that agenda. And then it's fair to say there is an enormous restructuring going on in the NHS at the moment. So NHS England will be integrated back into the Department of Health and Social Care, and those arrangements have been happening over the last 9 months or so. And it was announced that will be half the number of ICBs, and they would also reduce in headcount by 50%. And we know subsequently that there will now be a Thames Valley Integrated Care Board in future. That is being approved. Next slide, please. So as I said, this is a whistle-stop tour. It is a very truncated assessment of where we're at. And for those people who'd like to know more, please read the annual report. But the document that I often go back to, and I find most helpful, is actually the quality account, the trust quality account, where you get a lot of that. And the first bullet point here relates to that. And that actually our quality account shows that we were able to maintain strong clinical care standards and continue to improve our services. And the quality account, for example, identifies areas in relation to patient safety, falls, pressure sores, patient satisfaction, where we made improvements. I'm also pleased to say that post-pandemic, we've driven down quite a few of our waiting lists where we've had significant issues. The one exception to that is with neurodiversity assessments, both for children and adults. The number of assessments coming through and referrals has more than doubled. Our activity has also doubled, so we're doing double the amount we were pre-pandemic, but actually the referral rate has gone up. It is a national problem, and a national task force has been established around ADHD, which has been established for a while now. It's taking a long time to report back. I suspect that's because it's quite a complicated issue, but it will have to have some national guidance to address the issue. And then Paul is going to present immediately after me, so I won't steal his thunder, but just to say that we were one of a small number of organisations who were able to maintain those clinical standards and actually balance the books financially. And Paul will talk about how we did that in a little bit more detail, but it did put us in a fairly unique position. Next slide, please. One of the things that I talked about part our own journey into digital is that we increasingly automated many of our processes. So referrals coming through, being triaged, whether that be in community nursing or in physiotherapy, and that has really helped to save significant hours of administrative time and efficiency. And obviously we're going to build out in terms of that. And then we've been really able to exploit our connected care data insights. Connected care is the way in which we join up all the records, both health and social care, across the area. so that actually we're able in the real time to be able to see key information from acute, primary care and social care, but we're able to use that insight for secondary purposes to identify populations most at risk, those people with long-term conditions who haven't had physical health checks, who we need to actually get to. And it will allow us really to start the process of being much more precise around addressing health inequalities and target our interventions, which is going to be really helpful, particularly given the scarcity of resource and ever-increasing demand. And it helps us with that shift to prevention, really. Next slide, please. One of the things that stood out, I guess, during the course of the year, and it's been a feature now for almost a decade, is that the culture in the organisation continues to have real purpose, compassion and evidence-based practice, and we were delighted that we came top in the sector for staff engagement in the NHS survey last year. People recommending it as a place to work, people feeling that they have a say in how the organisation is run, and with high levels of morale. Not universal, but that's the outcome for the organisation as a whole, and amongst the very, very best in the country. We also improved engagement amongst Black, Asian and ethnic minority staff, and that really highlights the work that we've been doing both internally and with external support with our partners and some of the people on this call around our anti-racism programme. But there is more to do, with significant racial abuse still persisting, particularly in places like Prospect Park, where Black, Asian, minority ethnic staff are still regularly and routinely abused racially. So more to do, but with some positive signs of progress there. Next slide, please. You can't do any of this without working in partnership. So key partners, with the Royal Berkshire, with Frimley Health, with our 6 local authorities, primary care, and increasingly our voluntary and social care sector. And that, if you think about what I said in my introduction in terms of the 10-year plan and government priorities, we're going to have to really put rocket fuel under that. And as I said, we're now starting to actively shape. We're an actual partner in the transition board. Alex Gill, the Deputy Chief Executive, is a partner on the transition board, which will see the developments of that Thames Valley Integrated Care Board and effectively the coming together of the Buckinghamshire, Oxfordshire, Berkshire West and the Frimley ICBs, which will start from the 1st of April. And it's great that Alex is helping to shape that bit of partnership work there, so that it will be as effective as possible from the 1st of April. Next slide, please. And then just my penultimate slide, again, some significant changes at board level, which we formally noted in the annual report. Minu, who'd been a great colleague for many years, he was the medical director, retired, although he was appointed a non-exec director of the Royal Berkshire Hospital, so that's a really great connection for us. Tolu became the new medical director, bringing fresh insights to the leadership team because he came from a trust in the north, TZS Conwea. Tamina, who was our Chief Operating Officer, moved to the Welsh NHS, and Teresa has been appointed Interim Chief Operating Officer, and she was an internal candidate, and that's ensured we had a bit of stability there. And then we said farewell to a long-standing non-exec director, Naomi, who chaired fantastically the Finance and Performance Committee after a long service, and Sonia Batchelor was welcomed as her replacement. And then finally, in terms of that recognition, Martin, who was a truly fabulous chair, stepped down just after short of 9 highly successful years in the role. He's gone to chair Hampshire Hospitals Trust. Spoke to him only on Tuesday, Monday, actually. He's doing really well, and he left a fantastic legacy in the organisation. Next slide, please. So a couple of things in terms of my final slide. There's no question about it. You just have to look at the media, read the media. The performance of the NHS is under the microscope. There is a heck of a lot of change happening. I would say, in summary, although clearly we also have our challenges, I think we're well positioned, and we positioned ourselves well over the last 12 months to kind of face into those challenges. And we do have a track record of delivering our plans and establishing year-on-year improvements. and just take this opportunity to thank all the governors on this call this morning, to thank you for your support and the contribution you've made to the culture and improvements over the last 12 months. Thank you. Mark, if we go to Paul perhaps, and then we could pick up any questions if there are at the end.
By all means, that would make sense. Paul, over to you.
That's fine. Are you able to share the slides for the finance section?
Yes, I'm just bringing those up for you now.
Thank you. So while they're coming up, just say, for those that don't know me, I'm Paul Gray. I'm the Chief Financial Officer at the Trust. Thank you, perfect timing. And we just got the next slide, please. So if we just start with what we plan to do in 24-25, so the Trust has a requirement to break even in support of the wider financial position in Buckinghamshire, Oxford and Berkshire West. We increased our plan and we planned for a surplus of 1.9 million. Within that, we challenged ourselves to deliver 13.6 million of financial efficiencies. From a capital investment perspective, we had plans to invest 15.6 million in estate and IT, which we agreed with our ICB colleagues. And as a result of that capital investment and the modest surplus, we anticipated that we would see a reduction in the Trust's cash reserves of 5.8 million. If I can get the next slide, please. So if we turn now to our actual financial performance against that plan, I think we would say that it was a successful year. So with the help of colleagues who continue to really keep a focus on financial management across the organisation, not only did we deliver our planned 1.9 million surplus, but we went beyond that and delivered a 4.9 million surplus at the end of the year. So that effectively breaks down as the 1.9 million operational surplus we planned, and then there was a £3 million income allocation which was earned in 23-24, but we weren't notified of until mid-year 24-25, so it wasn't in our original plans. So recognising that additional 3 million of income moved our surplus to 4.9 million. You'll see there in the table, we saw quite a significant increase in income during the year, 32 million. That's made up predominantly of inflation funding that we get through our NHS and other contracts. Also includes funding for increased employers' pension contributions. We continue to benefit from additional funding for some of our services, so the Mental Health Investment Standard, which is geared towards increasing funding for mental health providers, and some specific service development funding from our ICBs, which enabled us to invest and open services like our new Poppy ward, which is expanded our mental health inpatient bed facilities. While our income grew, obviously our costs also grew. So we were exposed to national pay awards, which we needed to pay. We also recognised that in line with some of the investment income that we received, we grew our pay costs and our workforce, and our workforce grew by nearly 240 people during the course of the year. I'd say from a financial perspective, we did it in the right way, because at the same time, we also drove down agency spend and saw a 4% reduction overall in agency expenditure during the course of the year, and we managed our expenditure within the agreed ceiling levels that NHSE had set us. We delivered the 13.6 million of efficiencies that we expected to overall in terms of delivering our plan. And in terms of capital investments, although we didn't spend the full 15 million that we expected to, we did spend 12.8 million of capital, so nearly 6 million invested in improving our estates, So we've consolidated some of our estate in Reading and made some significant improvements to Whitley Clinic. We put a new dental suite in at St Mark's in Maidenhead, and we've begun construction of our new place of safety facility at Prospect Park and begun a full programme refurbishing all of the patient bathrooms, as well as a number of smaller health and safety and estates works across the site. And recognising, obviously, as Julian said, we're the most digitally mature trust in the country and rely significantly on our IT for provision of services to patients. We invested close to 7 million in IT kit and continued improvements in our digital infrastructure. And from a cash perspective, the better than planned surplus performance and the slight underspend against our capital plan meant that actually we saw an increase in cash of 1.4 million, which was better than we had planned. And I think, as you've already heard from our external auditors, hugely happy to see another unqualified audit opinion from EY. We can just move on to the final slide. Just context for the year ahead. We have again agreed a better than break-even plan for the year ahead, which again contributes to the overall system plan. We've got a higher level of efficiencies that we need to deliver in this coming year at 17.5, and we've also got a higher level of capital investment agreed for the coming year ahead at 22.8. Again, that driven predominantly by that high level of capital expenditure, we're expecting to see our cash fall by 7.1 over the course of the year. Thank you.
Thank you, Paul and Julian, for those presentations. It was very comprehensive, but as Julian said, it covers a huge amount of ground that the Trust has covered in those 12 months. So are there any questions from governors in terms of either of those two presentations? Graham, move to you.
Yeah, I'm intrigued by the use of the phrase cash. I'm sure I've asked this before. Do we mean reserves? I mean, in my terms, with local government finance, you know, you sort of have a reserve position, you have earmark reserves, you stick money away for a rainy day, blah, blah, blah. So can you just expand on the use of the phrase cash?
So, effectively, it is what it says. It's cash that we have in the bank. We don't have a significant amount, if hardly any, on long-term investments. So it's the cash that we've got available to invest in our capital programme, fundamentally.
So it's to say it has some similarities, Graham. The kind of terminology in local government is specific to them. It's more akin to a business. So liquidity would be what we're talking about here. And there are some rules for trusts about you know, how that can be spent and all the rest of it. But effectively, it's cash in the bank. And that's what underpins our capital investment, predominantly in buildings and in infrastructure. It is used slightly differently to the way in which it is in local government, I have to say, having spoken to the chief executives there. But there are some similarities too.
Thanks, Graham. Megan.
Thank you. Yeah, my question was just on the pay costs. So you were given extra income because of the increase in I forgot what it's called, national insurance, and various other things. And you were saying you've had more staff, more permanent staff, and you've decreased in agency. I was just wondering how pay costs this year compared to pay costs the previous year, just to get an understanding of that a bit more.
Beyond saying they've gone up, I'd need to come back to you on the actual figure. I've not got it to hand.
But it's gone up a bit, has it?
Pay costs rise on an annual basis. So
yeah,
pay inflation would have been, I think, overall probably close to 4%. So I think the funding increase alone on pension on the pension contributions was 7 million as well. And then you've got the increase in the actual workforce numbers that we've seen, which, like I say, we've managed within the financial allocations which we've given, which I think is the most important thing.
Okay, so that extra 32 million, quite a lot of that will have gone on pay costs.
Yes.
So that's I'm trying to understand. Okay, that's brilliant. Thank you very much. Thank you.
Thanks, Megan. Baldo.
Thank you, Mark, and thank you, Paul and Julian. That was really positive numbers and everything report we saw. Just a quick question on cash again, actually, on the balances in the bank. Do we sort of invest it somewhere for it to earn some interest, or maybe some other type of, making the money work for you? I didn't see that in the figures to see if there's any other income like that coming in.
So we do. There are rules in terms of where we can invest. Obviously, there was a lot of change in the rules after, you may remember many years ago, the Icelandic banks and many organisations lost money on that. So we're governed by in terms of where we do. We do invest it in overnight funds. We've obviously got a balance between getting access to the funding and how long we can secure it, which we keep under review. So I'd say at the moment we have conversations periodically with our finance and investment committee in terms of the options, in terms of where we invest. So we do put a fair amount of it on overnight investments.
Thank you.
Thank you. Any other questions for Paul or Julian? No? Otherwise, thank you both very much for that presentation. It's certainly a summary of being what appears to be a good year for the Trust, and it's much appreciated in terms of that review, which we'll hear again this afternoon at the AGM. Now, one of the subjects that the governors often raise is that of patient safety and the learning that we gain from that. And so next on the agenda, Dan Badman and Helen de Gruchy are going to give us a presentation in terms of the current work that's being undertaken in that area. So over to you, Dan.
Thank you. Hi, everyone. I'm Daniel, and I'm a Deputy Director of Nursing here in BHFT. I'm going to hand over to Helen, who can introduce herself, who's going to lead on the presentation, and then we'll have some time for any questions at the end. So over to you, please, Helen.
Thanks, Dan. Morning, everyone. I'm Helen de Gruchy. I'm Head of Patient Safety at Berkshire Healthcare. And thank you for asking us to give a presentation on patient safety. So Dan or Julie, hopefully one of you's got my presentation to share, because I'm just working off one screen. And hopefully I've pitched it at the right level, and that I'm going to give you some useful insights into our progress with patient safety. But obviously questions and answers at the end will be appreciated if I haven't quite pitched it correctly. So you may be aware that back in 2019 there was a national patient safety strategy developed. It was the first of its kind. There's never been a national strategy before. And my purpose today is to talk you through briefly the different elements of that strategy and what we've progressed and implemented in Berkshire Healthcare. So next couple of slides, please. I don't know if it's Dan or Julie doing this. Thank you. And the next one. So just to give some context to what the strategy is, as I say, it was developed 6 years ago. Then we obviously had COVID, which delayed some of the implementation nationally of some of the other arms of the strategy. But there are basically 7 main arms, of which relate to training, which relate to how we respond to incidents, which relate to the medical examiner process, etc. So I think if I go through each one individually with our progress, and then you'll see what we've done. So with regards to patient safety training, nationally a syllabus was developed, which again was the first of its kind, which is now ensuring that anyone who comes into healthcare has the same level of patient safety training, whether it be in their graduate, if you're a medic or a nurse or an allied health professional. So even in training now, patient safety is involved at undergraduate level, but then also as you progress through working in the healthcare system, there is now a requirement that you undertake some patient safety training. So there's different levels to the syllabus, and level 1 we agreed as an organisation we would make mandatory for all our staff. So regardless of whether you were clinical or non-clinical, and you can see we've achieved nearly 100% compliance with completion of that training. It's very short, but it does give a very clear insight into all the different aspects of patient safety, with the aim of trying to make everyone understand that everyone has a responsibility for driving patient safety in everything that they do. Different levels of the syllabus, levels 3 and 4 are the highest levels at the moment, and they're only open to patient safety specialists, which you will have noticed in my first slide. Patient safety specialists is another area of the strategy. So all organisations should have identified who their specialists are, and they should have undergone that training. So myself and there's 3 other members of our team who are our specialists, and say it's our responsibility, along with all colleagues in the organisation, but our responsibility to drive the overall strategy. And then we've also got some of our own in-house training packages, and we've also commissioned some additional training to really ensure that we upskill our staff on completing investigations, which is another arm of the strategy. Thank you. So that one of the key areas of patient safety that's been around for a long time is our patient safety incidents and how we respond to them. So for those that may have some insight into patient safety, we used to have something called the serious incident framework, which meant that every time there was a serious incident, we had to respond. It was very blunt. It was all about the seriousness of the outcome. Changing. And whereas now the new framework that we now operate under, sorry, Dan, I don't know what's happening to if it's Julie, sorry.
It is me, sorry, has it gone to a different page?
Yeah, no, it doesn't matter. It's just showing lots of things showing 3 slides on the page. So we now have a new framework, which means that we don't have to just respond to those serious incidents, that we can be more proportionate. We can be guided by what we feel at Berkshire Healthcare are our local priorities for safety. Whereas before it was a lot more governed by the outcome. So I like to relate to that as our Goldilocks moments. So we're looking for events that happen where things have gone wrong and harm has potentially been caused to patients, but where we can really utilise those events to significantly learn and ultimately significantly make changes and improve. Next couple of slides, sorry, Dan. And the next one, thank you. Lots of detail in this slide. It's not particularly easy to read, but I just wanted to highlight the number of patient safety learning responses that we've done in the previous year and the different patient safety incidents that we've covered. So we completed, I think, almost 90 learning responses in the last year. Under the previous framework, they were always, as I say, known as serious incidents, where you only could utilise one approach to investigate. In the new framework, we don't have to just do our serious incidents. We can actually do some incidents where there's lower levels of harm, and we utilise very different methodologies. We don't just use root cause analysis. So we use much more timely responses. We're much more about involving the staff perspective and the patient and family perspective, which I'll come on to in the next slide. So under the new framework, one of the key focus was about involving those who've been affected by patient safety incidents. So when something's happened and something's gone wrong and we want to explore it, we need to get the perspective of the patient and the family who may have been infected, and also the staff. And I think that's one of the key changes that we've made in the last couple of years, is around how we start to see our incidents through a different lens. So through the lens of the patient and the family, because they give us such a different perspective on potentially what happened, and also through the lens of the staff that were involved, to ensure that their voice is heard. If you go through the next slide, Dan. Thank you. I think probably one of the key things that you'll be interested to hear is So what? So we do a number of investigations, we do a number of reviews, we do lots of different methodologies to come up with findings. What do we do with those findings? So a number of our reviews and investigations lead to some of our, they either already link into some of our improvement work streams, or they are used to develop and design new improvement work streams. So working out where we need to focus our priorities on improvements. We also use our reviews and investigations to inform some of our training programs, and I think probably critically in mental health, our new clinical risk training program, a 5-day program, has been heavily informed by what we've learnt by things that have gone wrong, our patient safety incidents, and in our physical health, around our deteriorating wounds. So we know that wound care is a significant part of our community nursing and our community wards activity, and so therefore our findings have been used to inform training around that. And we also use our findings to inform new processes. So I've just given a couple of examples in there of new processes that have changed as a result. And obviously, as Julian pointed out in his presentation, we have seen a reduction in some of our patient safety incidents, such as pressure ulcers and falls. And that is as a result of some of the reviews and investigations we've done and the improvements we've put in as a result. Thank you. So I've already touched on that under the new framework, our involving patients, involving families is critical. I've been in the organisation for over 10 years, and the duty of candour, which is our duty to be open and honest when things go wrong, I feel has always been a huge strength of this organisation. With the new framework in the strategy, it's only done to made sure that we implement it even more than we already have. But I think for us, it's always been something that we've been really passionate about. And I've just given some examples there because we also have a family liaison practitioner now. So this is a new post, not all organisations have them. And the role of that post is to work with our families when they've been affected by patient safety incidents. So normally at the moment when our families have been affected by unexpected mental health deaths, our suspected suicides, but our family liaison practitioner also reaches out to some of our other families or patients that have been affected, and her role is critical to ensuring that they feel supported, that they feel that myself as part of a review team listens to their voice and gets their perspective. Thank you. By involving our staff more in our patient safety incidents and reviews, I say we get to hear their voice, they have a different perspective. And this all leads to our safety culture, which is another integral part of the strategy. So our work on safety culture has been embedded in the organisation for a number of years. And that's to ensure that there is a collaboration between our staff and our patients to make them feel safe, to make them feel able to speak up, to make them feel able to raise concerns. And we do that all the time through our patient safety reviews and investigations. So it's about creating a safe space and ensure that, as I say, they're able to speak up about what they've experienced and why they think things go wrong, because they're often the best people to help us identify the improvements. Another arm of the strategy, which we've touched on, is about involving patients and patient safety partners. So we have a very active lived experience workforce in the organisation, and so a number of our patient safety partners come from that workforce, but we also are fortunate to have 2 individuals who also focus on patient safety partner work, and that's again about ensuring that the patient's voice is heard, whether it be in terms of looking when things have gone wrong, or when we're looking to improve or change our processes or change our pathways to get their perspective. And this is just some examples of some of the things that we've done to ensure that we involve patients in patient safety. Thank you. So I touched on the safety culture because I think the thing with the strategy is, whilst there's lots of different arms, they all link, but safety culture is the theme that runs through everything. And as I say, we've had a safety culture committee in the organisation for a number of years who've made enormous strides in ensuring that there is collaboration between staff and patients and families to ensure that there is safe practice to ensure that staff feel safe in speaking up about concerns, and also to ensure that we are supporting an equitable and diverse workforce. So I think, I'm not sure whether you've had presentations from them before, but you say there's a significant amount of work that goes on under the safety culture umbrella. And then the last two parts of the strategy around medical examiner and learning from patient safety events, I haven't done specific slides on because that's more business as usual. Our medical examiner process ensures that all of our community inpatient deaths and deaths from at Prospect Park that don't go to the coroner have scrutiny from an independent person, and that also ensures that the family are supported through that process, and it's a really strong way of ensuring the governance of deaths comes back to the organisation. So if the medical examiner scrutinises a death and has any concerns, then it will come back into our organisation to decide whether we need to review it and what we need to look at. So it strengthens the patient safety and the ability to improve. And the learning from patient safety events is a national system that our local risk management system and our reporting of incidents feeds into. We're very much governed by how that is developed, and it impacts on, say, our local reporting system, which is Datix. We already have our own local system. We just need to make sure we keep adapting it to ensure that the national system is fed the correct information so that they can then triangulate and compare across organisations. These are some of the areas that we need to keep working on. As I say, some of them, like the medical examiner, is business as usual and very much set in how we work, but certainly how we respond to our incidents under the patient safety incident response framework, how we engage our patients, how we utilise our patient safety partners, and how we explore methods to monitor the effectiveness of our actions and improvements. They're the key areas that we need to work on moving forward. So I've spoken quite quickly. There was quite a lot of information in the slides, but hopefully that's given you a flavour and has given you some insight into what we're doing.
Helen, thanks ever so much for that presentation. You said at the start you hoped that you were pitching it at the right level. From my own personal perspective, that was ideal in terms of it really illustrated how many different facets there are to this subject, that it's not just simply one aspect that you're looking at, but many different areas. Governors, any questions for Helen or for Dan? Megan.
Sorry, I've just got a question. I mean, this is really from my personal experience and in managing risk in my day job. When you look at patient safety, when you review an incident and you realise that there's got to be a change in how you do things in the trust, how easy is that to implement, and how do you sort of monitor the success of that being sort of embedded in the trust? And can you give an example of something that where you have had to make a change and how you've kind of reviewed that and checked that it's actually become a permanent fixture within the organisation? Thanks.
Helen, do you want to go first, or do you want me to?
You answer the first and I'll answer the second. That's all right.
Yeah, sure. So perhaps if you wanted to give an example. So Megan, in terms of how we review an incident, so without going through every step, essentially the incident will be reported, and there'll be an initial review of that incident. For ones of interest, they'll come to the patient safety team, where the patient safety specialists sit, who will have that expert knowledge on how best we can find the right learning and actions from it. So we consider what approach we would want to take to analysing what happened with the incident. So there's different methodologies of investigation that we'll use at that point. So one of the ones that we're starting to use a lot more is something called an after action review, which I think originates from the military, where you look at the process as it should have been done, look at how it was implemented, and look where the gaps are to identify where those process issues that may not have worked quite right. And then from there, often with an AAR, we'll be able to find some fairly straightforward actions that we can take. That might be about updating a process or implementing some standard work. So that we'll do that with some of the more probably straightforward ones. The bit that we've been really working on over the last year and need to continue to work on over the next year as a focus is around how we join up and make effective actions for some of our more wicked complex challenges that we have. So particularly in our community services, it's very different to perhaps in an acute hospital. There may be a surgical error, you know, something happens during surgery where that may be quite straightforward. We're working in a really complex system with social care, third sector providers. People have the right to make their own choices about how they live. They're really quite complex issues. So for those, how we work is alongside our quality improvement, which is really well established in the organisation, and we try to utilise our quality improvement approaches to address some of those challenges. So for instance, it may be that we ask a team to go back and take an issue that's been found to their CUMUS huddle for the team themselves to find the solution if it's a local issue. So it might link things to our work streams that or in user work stream that is a bit more complex. So for instance, we've shared learning from instance with the one team work stream that has then gone on to consider how they're going to make the improvement as part of that work program, if that makes sense. So it's varied depending on how complex the issue is, and but I definitely think over the next year, and we've had some recent meetings with our quality improvement team, we need to get patient safety and quality improvement closer and closer together to solve our challenges.
Thank you. Helen, did you want to pick up the
so I just had a quick couple of examples. So I mentioned about deteriorating wounds in the community, and obviously we don't have the luxury with our community staff of having our laboratories, our resources, etc. on one site like the acute hospitals do. So we've had a number of cases where a deteriorating wound needs a wound swab to identify what antibiotics are needed. But the number of steps that were required for us to even get the results of that wound swab to know the right antibiotics that required the GP to prescribe them creates delays for the patient, opens up the door for the increased risk of sepsis. So by going through a QI process, once we'd identified that actually not that many nurses could take wound swabs, that we relied on the GPs, etc., we've made changes so that now there are more people in community nursing teams that can get results. So we don't have to rely on sources outside of our organisation to give us the results. We've also got more community nursing staff now trained and are able to give broad spectrum antibiotics to at least give a cover for the period of time whilst the results of the wound swab are coming back. So that's all come as a result of us identifying that the wound swab, which we just assumed, nurses take wound swabs and wait for the results, will then give antibiotics, all takes a period of time. So we've reduced the time and increased the practicalities and the abilities of other people and things to be able to, as I say, to give prompter antibiotics.
Thanks, Helen. Thanks, Megan. Sarah.
Hi, thanks, Helen. Thanks, Daniel. Really, really informative. I didn't really know much about the service before, so thank you for sharing that. It was really good. The question for me, I guess this is quite a holistic view across all of Berkshire East and Berkshire West. I just wanted to understand if there were disparities between East and West or any learnings that you'd taken from the different areas.
So as a patient safety team, we cover the whole of Berkshire, but yes, our learning responses, especially our investigations and reviews, do find some disparities. One most recently is we found a difference in how our ARS workers, so they are mental health workers in our GP practices, partly funded by us, partly funded by other sources, they work differently in the east to the west. And we've identified that there are some practices in the west that work better than in the east. So as a result of that, there is now a plan to try and standardize the approach, how they work, how they triage, which patients they're allowed to see. So yes, there are some disparities. The same with our community nursing. We had 6 community nursing teams across the 6 sort of same as the local authorities. And there were disparities in those in the east and those in the west. So they're now working more cohesively together, having the same standard operating procedures, having the same processes, so that because you need some differences because some of the populations are different, but the standard processes, etc., should be the same.
Thank you.
Thank you. Ros.
Thank you for a very interesting presentation. It's really helpful to know more about the patient safety work going on. Couple of quick questions. First one, in relation to the training that staff are required to do, you indicated that there's a very high level of level 1 training for trust staff. I just wondered, does that include contracted staff or just trust employed staff? So for example, the new Poppy ward, are those staff included? And what about domestic staff and other people that work for private contractors?
That's a very good question.
No, it's a good question. Currently it includes trust employed staff, Ros, but it's a good challenge actually. We can take that back for some consideration. I think for Poppy ward, there's an element of about thinking about how we arrange those contracts and what our expectations would be of them in relation to patient safety training. It probably doesn't specify that, but there are a couple of points that we can take back, certainly. And with the national patient safety training, there will be variability with our partner providers when we're working with other people, because we've proactively decided that it's a high priority for us as an organisation, and I think that's a really positive step. But I know that, without naming them, I know that there are other organisations locally that are around 20% for that training, and I think that's a real sort of gap. So, but we'll follow that up. Helen and I will follow that up around particularly the question around NHSP staff, actually, because I think that's a significant factor for us.
Yeah, thank you. Because I think it could be rather misleading when it looks as though so many staff have been trained, and to patients they don't necessarily distinguish between trust employed staff and other staff. They expect everybody to be trained. Thanks. And my other quick question related to your next step slide, where you said you'd like to engage more patients and patient safety partners. I just wondered how you're going about that, and if there are people who are interested, how can they get involved?
So if people are interested, then to contact myself or our head of patient experience, who oversees the lived experience workforce. In terms of how we just need to raise the profile of that we are supporting like the patient safety partner role. So in our reviews and investigations, I want to involve a patient safety partner each time, because they look at a different lens. I would like to be really brave and do what some trusts in London do, and actually invite the patient into the after action review. So if a patient has fallen, let's say, then let's actually bring them into the process, rather than we will always speak to them outside of the process, but actually bring them in. So I just think there is a wealth of opportunity to grow that part of the strategy, and I think in a way for me that probably is the one that where we've we've got more scope to do more. But let's not forget there are a number of individual services that might be involving patients that we're not so aware of as a patient safety team in lots of their work streams, but specifically around patient safety, I think there's scope to involve them in our reviews and investigations to get the view through their lens.
Thank you.
Thanks, Ros. John.
Oh, Helen, lovely presentation. Thank you. I've been very busy the last 4 months with a patient, my daughter, who's going through a lot of hard times and probably 4 or 5 different specialities. But you look at serious incidents and go down to local priorities, lesser incidents. She probably fits into that category of lesser incidents, but they all come together, a lot of them together, causing to have unusual presentations. And our aim is to try and prevent death or severe disability. Or I'm looking at it from one person in perspective, and you look at everyone in perspective. How much funding is spent at each level to get systems working together? And I'm looking at the whole country as a whole, where we have systems and GP surgeries, which are all different, trying to get appointments for relatives you worry about. Like you were saying, mental health practitioners and GP surgeries, she has one, and I didn't know about it. Because they're different in different places. She's down in the south of the country. So this communication that could probably help. Very complex and very dear to my heart at the moment. So I'll be happy to work with you, Helen.
I'm sorry to hear that you're going through that, John, but that would be great to have you involved. So thank you.
Thank you, John. And thank you, Dan and Helen, for what was a very good overview of the work that you're doing, which is so critical in terms of how we're learning and supporting patients to create that safe and maintain a safe environment. So it's greatly appreciated. If any of the governors want to be more closely involved with Helen and Dan on this work, please do drop them an email, because I'm sure they'll be very appreciative of your support. Thank you.
Yeah, thanks for having us.
Thank you. Bye.
Just moving on then to the committees and steering groups. We've got reports included in the pack from the 3 different committees. Taking first membership and public engagement, Brian, is there anything that you want to add to your paper?
No, there isn't at this point, but I'm happy to answer any clarifying questions if they arise.
Any questions for Brian on that? Otherwise, the quality assurance group. Any questions for Sarah? Any points that you wanted to make, Sarah?
No points for me. Just an observation, though. I did include in there the forthcoming dates for 15 steps and service visits. So just to ensure that all governors are aware of the ones that we've got NEDs, etc., already lined up to. It's on the spreadsheet that's sent out to you anyway, but I just wanted to make sure that was clear for everybody, because I know sometimes navigating through that large spreadsheet can be quite challenging. So just wanted to make it easy for people. And that's on page 24.
And then living life to the full. Madeline, any points that you wanted to add to your paper? Or any questions for Madeline? No. In which case,
sorry, I couldn't get the microphone on.
That's good.
For which I apologise. I did just want to add, if I could, that we have just started working as a result of our latest meeting with the housing staff at Abri, looking at how Abri staff, particularly what they call the independent living partners, that is the new housing officers, of which they have much smaller groups of people to look after. But Abri are interested in making sure that those people are much more mental health aware, and that they are wanting to work with us, and have started to do so by asking us a few questions they are wanting to work with us to make sure that their staff are sufficiently trained to be alert to any possible alarm bells from community members, so that they can be reassuring in the social communities that people are reactive with one another and supportive to make sure that their mental health is the best it can be.
Thank you. Point well made. Thank you, Madeline. Any questions for Madeline, either on that or her paper? In which case, if we move on to the executive reports from the Trust, can't see Liz. Is Liz Chapman with us?
Yes,
I'm
she
here.
is.
Oh, super.
Good morning.
Liz, do you want to take us through the quarterly patient report and experience?
Absolutely. Thank you very much, Mark. Please excuse me, I'm just getting over COVID. So if my voice suddenly goes, I do apologise. For those of you who don't know me, hello, my name is Liz Chapman and I'm the Head of Service Engagement and Experience. So you will have already seen our Q1 patient experience report, but what I've done, as I often do, is just collate a few slides as a summary to kind of share those highlights with you, but also give you some information about some other work that's going on around patient experience. Okay. You will have seen this table in your report. So this is the overview of the Trust summary, except what I've done here is I've added Q1 onto the end of the previous financial year, just so you can see over time how we're doing. You'll see that our number of responses for I Want Great Care, which is our patient feedback solution, has continued to increase. We received around 200 more contacts through I Want Great Care in Q1 than we did in Q4, which is fantastic. And we continue to see this upward trend in people sharing their views with us. In terms of our response rate, obviously, that means we're also seeing an increase. We have a kind of baseline target of 10%. We're still trudging along to that at the moment. And I'd just like to make it clear that the way we calculate our contacts is for outpatient appointments and discharges, whereas some organisations do this purely on discharges. So whenever you see the percentage for a response rate for the friends and family test, something to bear in mind, we're looking at it as every contact counts and every contact can and is a different experience. And that's why when you look at our response rate compared to some others, it may seem low. As an organisation, we feel it's more representative. You can also see that in terms of our experience scores and our 5-star score for the I Want Great Care, we're around the same, which is good. It's always good to see that when the number of responses is increasing, that we're maintaining that high level of patient satisfaction. And whilst we're talking about patient satisfaction, our compliments, they continue to increase. So these are compliments that services are receiving, and they're popping them on. You've heard the word Datix a lot today. I've caught the end of my colleagues, Dan and Helen. So our reporting system, we use that for compliments as well. There's a really quick and easy form that people can fill in, and it just captures the number of compliments they're receiving at a service level. Reason why we ask people to do that is when we look at patient experience, it really is that balance. And I know that a lot of it is around what we're regulated on. So things such as the friends and family test and the complaint activity. Compliments really do give us that balance, and it's great for our staff to also see the numbers and the feedback that they're getting. Leave that there for a couple more moments. Like I said, this is in your paper. Okay, so in terms of I Want Great Care, things we're doing particularly well. So we're particularly well at involving our patients in decisions, respecting their preferences, and for the emotional empathy and support that our staff are sharing with the people that we care for. Areas where we can improve are around continuity of care and transition, and the involvement and support for carers and family members. Here's some highlights in terms of our complaints and PALS activity. Excuse me. So for Westcall, our GP out of hours, and CRHTT, which is our crisis resolution home treatment team, that's a mental health service, they saw the highest decrease of formal complaints compared with the previous quarter. We monitor at the outcome of complaints. So that's upheld, not upheld, partially upheld. And it's something we're really interested in as an organisation. And we've been monitoring this for some time. We can see that last quarter, 54% of complaints were either partly or fully upheld. And that's a slight reduction compared to last quarter. And it's around the same as we've seen previously. However, the big difference last quarter was we actually closed significantly more. You can see that in Q4, we closed 30 complaints and we closed 55 in Q1. I'm sure, I know Julian's on the call, he signs off every single complaint response. I'm sure he would agree that we've definitely closed a lot more complaints recently. You'll notice something different in the Q1 report, and that's around our monitoring. So something we introduced about 18 months ago was looking at our patient survey and our complaint activity by demographic, so ethnicity, disability, and age. What we've started to do is go that bit further. So not only are we looking at what the results are, we're now starting to kind of really deep dive in. So within the Q1 report, for example, you will see we're now monitoring the outcome code. So upheld, partially upheld, not upheld, by ethnicity. It's the first time we've done that. And we're going to continue to monitor that this year. And we're going to be bringing in our other forms of kind of cross-checking and monitoring, working with our colleagues in our health inequalities team to really make sure we're understanding the experience of the people who are raising complaints and giving their feedback. In terms of learning from complaints, one of the highlights recently has been around the named worker in our CRHTT, so our mental health crisis service. And that was brought in a little while ago based on patient feedback. And that's where, wherever possible, a patient who is calling the crisis team will have a named allocated worker. So there's that consistency and that continuity and that trust. We know that people, when they're ringing crisis, you know, it's really helpful to have a consistent approach and a consistent person that they're sharing their concerns with. We're monitoring that through our patient feedback, which includes complaints at the moment. The CQC. So as you may know, there's something called the early resolution process, which is how the CQC look at and respond to complaints that go through to them. It means that rather than necessarily going down a full formal complaints process through the CQC, they will contact us and say, you know, can you have a quick look? Is there any feedback you can initially give us? And we didn't have any contacts from the CQC around that kind of early resolution process over the last quarter. We were contacted by the PHSO, so that's the Parliamentary and Health Service Ombudsman, about 2 potential new cases. They haven't been taken forward for formal investigation as yet. What happens is the PHSO will contact us, ask for a copy of our complaint file, ask for a copy of our medical records, and then they will do an initial assessment and make a decision as to whether or not they're going to take the complaints through for further investigation. We've not heard yet and whether that's going to happen. What I would say is our conversion rate is low. So whilst we may be contacted by the PHSO, very few get taken forward for a further investigation. And PALS, our Patient Advice and Liaison Service. So this is our inquiry, information and signposting service. It was a very busy quarter last quarter. We had 526 contacts that were for our organisation. But in addition to that, we had 397 that weren't us at all. Predominantly, these were for the Royal Berks. I'm sure you can understand that you put in Berkshire, NHS, you know, it's probably going to be one of 2 that come up, and it's normally us at the top. So we work really closely with the Royal Berkshire Hospital and our colleagues in their PALS and complaint service to share with them the areas that we're getting contacted about. And we ask people when they contact us, how did they find us? 9 times out of 10, it's a search result on the internet. Sometimes, however, we have found some stray posters of ours in RBH clinics, particularly where there's a shared site, such as King Edward's or West Berkshire Community Hospital. Sometimes they'll very helpfully put up our learning from experience poster and not the RBH's. but we have a no wrong front door process in this organisation. So rather than say it's not us, we say we'll find out who it is and we'll get that over for the person. What else have we been up to? 15 steps. Thank you, Sarah, for the plug. Much appreciated. Love to have governors involved in 15 steps, and we do have dates left up until the end of March before we start our schedule for next financial year. And in November, NHS England are going to come in and shadow us and going to pilot some new paperwork. The 15 steps programme now has been around for some time. And so we're looking to kind of reinvigorate it a bit, make sure it's still fit for purpose, bring it up to 2025. So we're really looking forward to NHSE coming in. Co-production. So we're working alongside colleagues in our QI, our quality improvement team, to review a strategy, make sure we've got clear direction setting and clarity so that we can enable our services to really do a genuine co-production. A couple of areas of note at the moment. So we're heavily involved in the 16 to 25 transition project, and we're supporting the work around the secure transport provision for the trust. As at yesterday, we're going to be starting a piece of work specifically looking at patient stories and how we can capture those, the different methods of doing so, so that we can share them back with our trust board, with our staff, with our communities, so that we can really bring our organisation to life through the lens of the patients and their carers. Our annual CMHT survey is underway. We do this every year. It's via the CQC. And our response rate is normally between 20 and 25%, which is very good. And the results for this will be coming through next year. We have our patient experience framework. So back in February this year, NHSE announced a new framework, and we're busy working behind the scenes, gathering a baseline ready for March 2026. The framework isn't actually mandated for non-acute trusts at the moment. However, we recognise here at Berkshire Healthcare, this is about best practice. This is about celebrating what we're doing well and sharing that, but also understanding where there may be some gaps and some opportunities for improvement. So you will be seeing and hearing more about the framework as it comes to life. It will culminate in a 4-year plan of how we're going to monitor and improve patient experience. Place assessments. I know a couple of you have been involved. They started last week at Prospect Park Hospital, and this is the patient-led audit of cleanliness and environments. They're continuing till mid-November. If anyone is not involved and would like to be involved, please let me know and I can share the dates with you. Big shout out to Ros, because I know she was there on Friday. And our lived experience workforce programme. So I heard Helen and Dan just touch on patient safety partners. So they're kind of an independent role to lived experience. We currently have 35 substantive posts in our organisation. This is fantastic. We're continuing to work behind the scenes to build the infrastructure and the support and the progression to really enable people with a lived experience of our organisation coming and working for us. We're getting some great feedback, which culminates in the winner of our non-clinical staff member of the year this year, Laurie Cunningham, who works over at CRHTT in the East. Really proud. We had 8 nominations this year across our lived experience workforce for the staff awards, and Laurie won the non-clinical. Very briefly, I will ensure that this gets circulated. Here's a piece of co-produced work that we did as a patient experience team with our lived experience workforce. We co-created a team plan on a page around lived experience that each lived experience practitioner or peer support worker took back into the service in which they're based. So they shared this to make sure that everyone is aligned in terms of where we're looking to go as an organisation around lived experience. Mindful that is a whistle stop tour. I've not been able to see any of you, so I apologise if any hands have gone up. If you have any questions, happy to take them now or after. Thank you.
Thanks ever so much, Liz. That was really useful in terms of a broad update that you gave us. And I was particularly pleased to hear of the increasing response rates that you're getting through I Want Great Care, which is something I know that you've been putting a lot of effort into. So it's good to see that materialising.
Thank you.
Any questions for Liz on her presentation? No. Okay. Otherwise, thank you, Liz.
Thank
Really
you.
appreciate your update.
Thank you very
Brings us
much.
on
I
to-
think Sharon had her hand up.
Sorry, I can't
Thank
see
you
any
very much. Who was that? Deborah?
Yes.
hands up.
Thank you, Deborah.
Sharon.
Yes, thank you very much. So I'm using my phone at the moment because I couldn't get on at the computer, so I couldn't quite actually see the spreadsheets that you was doing, Elizabeth. But I've noticed since I joined late that when the when the people are talking about the areas, we're being referred to as East Berkshire and West Berkshire. That means nothing to me because I live in Slough. And also, the areas that are failing are East Berkshire and doing well in West Berkshire or vice versa. That doesn't mean anything to me. So, we need to sort of like scrutinise town by town because some areas in Berkshire, they're a lot smaller than Slough. So what we need to do is highlight whether Slough has a big problem because it has more people, or whether maybe one of the villages in Berkshire has a bigger problem than us with less people, or Maidenhead or Windsor. So referring to East Berkshire and West Berkshire doesn't really tell me where we're sort of like where we're failing and who's doing good. So if we're doing good in one area, then I think we should reward those areas. Do you know what I mean? For the staff hard work, and then move on to the failing areas and see how we can fix them. I heard that, I don't know whether this is true or not, but a lot of people in Slough have tried to actually access the mental health services. They've tried to access the council for help. The police are doing a fantastic job in Slough, but they're not the mental health support. They're supposed to, but time and time again, they liaise with the council, get nowhere, and we have a huge problem in Slough with mental health. And some people leave because they cannot cope with being told, go to sleep and take another tablet, but by the crisis team, to be honest with you. And so when people, I suppose, when they get a little bit difficult, they get signed out. But when they commit suicide, and I find this really, really sad and hard to believe, that if they commit suicide and they've decided that they've given up or they've been signed off by the mental health services, that's not really classed. It's classed as a suicide, but there's no attachment to mental health services. I'm just wondering if this is correct.
Mark, should I
Liz.
pick up?
Thank you, Julian.
Yeah. So I'm Julian, Chief Executive. That's not correct, actually. I'm pleased to say, Sharon. So if somebody's been in contact with any of our services in the last 12 months and dies by suicide, it is classed as a death associated with Berkshire Healthcare. It is investigated as such, and it is treated as such, obviously, in the coronial process as well. So I can assure you that's not the case. In terms of the sort of crisis teams and home treatment teams, the calls are recorded and monitored, and I'm not sure when you spoke to somebody about the kind of advice, but the advice that someone would just take the pills and go to sleep and stuff is not advice that would be given out.
Yes, it is. Yes, it is.
And we're able to record that. So if you've got a particular case you want to follow up with, then we can do that because we record all the conversations. So we'd be able to look into that. Be quite helpful. I think you're right about the differences across Berkshire, and we are able to home in on those areas. So I think you missed my presentation at the beginning, but through our connected care and electronic record, we're actually able to identify differences in outcomes, differences in kind of challenges. And there are times, you're quite right, when we're doing kind of broad level presentations, when we refer to Berkshire or East and West, and that's kind of a more global level. But we are able to drill down to specific populations, either at town level like Slough or Reading, or even at a greater level of granularity than that. And so we can certainly look to demonstrate that if that would be helpful.
Thanks, Julian.
Can I just come back, Julian?
Of course, yeah.
If I can get a piece of paper with names on it that are using mental health services and being told this, and I've actually seen the staff tell people this when I've got involved with my neighbour. And so I've seen it from my own eyes. I've heard it with my own ears. And people are contacting me and telling me the same thing. So if I get them to sign a piece of paper, will you actually look into the crisis mental health team services in Slough?
Of course.
Because one life lost should never go. And I'm here as a public governor for Slough because nobody seems to be representing us apart from the police. And it shouldn't be the police's job. We're all supposed to be holding hands and getting together, and you rely on public governors to tell you what's going on in communities and stuff like that and try and help. And I'm coming forward and I'm trying to blow the whistle, and I feel as though I'm not being listened to. It's not my life, it's people's lives who I know, and I know that for a start, when I got back some of the figures for Slough, they can't be true because there's so many more people.
Okay, Sharon. We're very open to the suggestion. So yeah, of course, if you give us the names, we'll look into it. And we can do that. Absolutely. So that'd be really helpful. Thank you.
Thank you, Julian. Elizabeth, you wanted to?
Thank you, Julian. Thank you, Mark. Sharon, I'm more than happy to kind of grab a coffee with you and have a conversation about your experience and the experience that you've shared today. So, Julia, are you okay, please, to share some email addresses, please?
Yeah, of course.
Thank you.
Thanks, Liz. That'd be much appreciated. And Megan.
Hi, thanks. Just bearing in mind what Sharon was saying just now, I suppose one of the things about this whole interface between adult social care and mental health services from the NHS is, do we sort of monitor good practice and good relationships between when it works well between the NHS and adult social care? Because obviously we've got local government reorganisation coming up, and it would be good to be in a strong position where we can see where it's working well in some areas, and sort of to make sure that practice is, you know, when we reorganise, that practice is what we use, rather than not really knowing which is the best practice to use. Because I imagine that, you know, there'll be different challenges in different areas. I mean, Slough is much more urban than West Berkshire, so some things might not work elsewhere, but it would be really good to have some kind of benchmarking about where that relationship between the NHS, BHFT and the local government is working well. Just sort of going forward, I think would be incredibly useful. Thank you.
Yeah, thanks, Megan. Yeah, I mean, we do review this and from time to time actually talk about it. So when we do presentations on particular teams, so I'd say with 6 local authorities, we have a good relationship in terms of a sort of personal level. Actually, it does work quite well, but the way things are set up is different, and there are some aspects that are better than others. So particularly those areas that have de-integrated their joint teams. So in Reading and West Berkshire, the patient experience is not as good, surprise, because you bounce around from the two. And that de-integration has happened quite a lot across the country. So the joint integrated teams definitely offer a better experience, really. I think that's well known, but I think the reasons for the de-integration were for a variety of other reasons. So we definitely do have some insights into that, Megan, and we have talked to local authority. I do talk to my counterparts at the council around that. Thank you.
Thanks, Julian. And again, thanks, Liz, for the presentation. It's much appreciated.
Thank you. Bye-bye.
Thank you. Julian, can we just come back to you now for the performance report in terms of the trust?
Yeah, I just take as read. I never know what people are going to highlight, other than to say, just on sort of page 75, there is an update to the NHS oversight framework. So it talks about that being introduced. And a couple of weeks ago, the results were published, and we came out third in the national league tables. Got a message actually last week from the Secretary of State for Health, which is on our sort of website. So obviously pleased to be in segment 1 and right at the top of the table in terms of that. That's the only thing that's kind of changed since the papers went to publication. Other than that, Mark, happy to just pause and see if there's any particular questions on any of it.
Any questions for Julian to his report? No. In which case, we're on to Governor feedback session, which is the opportunity for governors to feedback on any specific external meetings, virtual. No. In which case, under any other business, I do have one item myself, which wasn't included on the agenda, which is the reappointment of the lead governor and deputy lead governor. And I'm pleased. Sorry, Sharon, have you got your hand up? Are you still on mute, Sharon?
Mark, emails. I am being bombarded with emails. Have a meeting, don't have a meeting, cancel a meeting, have a meeting, cancel a meeting, cancel a meeting. I'm like, oh my God. In fact, my computer backed up. I don't even know if I'm going to be here in 2026. But I'm supposed to be at a meeting that's been cancelled. So I just like, I've never had so many emails in my life. I think I had 36 yesterday. Add this to your calendar, take that off your calendar. Do we have to have like 2 years of emails, and then even before you change the system, a load of the meetings was cancelled? I don't know whether I'm coming or going. I'm lucky I got here late today.
Yeah, Julie, I don't know if you can say anything on that. I know a lot of emails came out yesterday with cancelling meetings, which appeared to be on the same days as meetings were then being reinstated.
Yeah, we do send meeting invites to everybody for the whole year. We did that, and then Cheryl used a different email, used a generic email address for all the meetings as well. So we cancelled one. We're changing over to a different system of doing the meetings. So fingers crossed, those meetings have now been put in people's calendars for 2026. So apologies for all the huge number of cancellations and meeting invites. It should all be calmer now.
Okay, we look forward to that calm after the storm. Thanks, Julie. Graham.
Yeah, I was simply going to interject on that I think that it would have been helpful to have the email that explained what was going on at the outset before we then received all the cancellations and because you get a whole series of cancellations and fresh appointments for the same day at the same time, and then a series of emails which update the times because the times don't match what you already had in your calendar. Having an email right at the outset saying, sorry guys, this is what's about to happen to you, might have been helpful. We got it, but it was in the middle.
I think that's taken on board, Graham. Thank you. John.
Yes, I was putting my head out a bit. Not that I've got any left. It'd be good to get just a summary of the meetings that are going to be occurring over the next year, maybe on just one page that we could go back to for reference, because there may be some meetings that that we've cancelled and I've crossed out in my diary, and if I use my diary and I've cancelled it out, I won't log on. So that may be helpful for us as a starting point.
Yeah, we can certainly send that round, John.
Thank you.
No, point well made. Thank you. The point that I wanted to pick up under any other business myself was the need for us to appoint a lead governor and deputy lead governor. And I'm pleased to announce that Brian Wilson is going to continue for the next year as lead governor and John Wellham as deputy lead governor. There were no other nominations coming forward, so thank you both gentlemen for your continued support. You're on the hook for another year, Brian. Thank you.
Yeah, afraid so.
Moving on, dates of next meetings. On the 12th of November, we've got notice of an extraordinary meeting, and that is to appoint a new trust chair. That will take place unless we're not in a position through the recruitment process to do so. But we will still continue with the standard meeting on the 12th, and then on the 3rd of December, the council meeting, which is an online meeting for everyone then. So at this stage, I was going to pass a resolution to exclude the press and public from the remainder of the meeting in terms of confidentiality. So if there are people that are not to continue into the next stage of the confidential meeting, if they could absent themselves from the meeting now. And then hopefully you've all got a copy of the